Okay. So good evening, Doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's session is very interesting and very important. That is thyroid disorders in pregnancy. And we have our guest speaker, Dr. Suchitra Jain, Madam, and Dr. Rana Bhattacharjee, sir. So before moving into the session, let's have a look on our Shield Connect page. This is a knowledge sharing platform of Shield Healthcare. Here you can find different blogs written by many eminent doctors across India in various topics. And these are the past sessions already we have conducted in our platform in various topics as well by many eminent doctors across India. And these are the COVID-19 awareness update. So here you can find different talks related to the COVID-19. And the most important thing is our key opinion leaders. Almost more than 300 doctors are currently supporting us this knowledge sharing platform, that is Shield Connect. So I request all the participants, please have a look on this website, as it's a very informative in terms of our subject area. So now it's time to start the session with Madam and Sir. And it's my honor to introduce Suchitra Jain, Madam. Madam did her MBBS in the year 1981 and MS in Gynae and Obstetrics in the year of 1986. She is engaged in private practice as consultant gynecologist in Kolkata and attached to Calcutta Medical Research Center, Research Institute, that is CMRI, Bhagirathi Neotia Women and Child Care Center, Sri Jain Hospital, Howrah, as senior consultant gynecologist. And during her staying in the Thailand between 2000 to 2005, she also worked with American and French NGOs at Thai-Burma border, and Madam is the Joint Secretary of Kolkata Menopausal Society. Now, it's my honor to introduce Sir, Dr. Rana Bhattacharjee, sir. Sir is the Assistant Professor and in charge Hormone Lab, Department of Endocrinology, IPGMER and SSKM Hospital. Sir did his MD in Medicine, MRCP, DM Endocrinology, FICP, FRCP, and FSC. Sir has received many awards, out of which Dr. J.C. Fetal and Dr. B.C. Mehta Best Paper Awards from Journal of Association of Physicians of India. Sir has also received AR State Award from the Endocrine Society of India. And apart from this, in terms of academic activities, there are more than 60 publications in national and international peer-reviewed journal as well. So with this short introduction of both Madam and Sir, I request both of you to please take the session. And meanwhile, I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam and Sir. So thank you very much, and over to Madam.
Yes. Should we start?
Yes, ma'am. You can.
First of all, thank you very much for your kind introduction, Saman. And now, good evening, all everybody. So I will be talking about physiology and pathology of thyroid gland and its changes in pregnancy. And then I will discuss about hypothyroidism. So I'm sharing my screen. Is it visible?
Yes, madam, it's visible. You can start.
Audible as well?
Yes, ma'am.
Okay. So, friends, let us go back to our college days and refresh the classes all of us took on physiology of thyroid gland. So, let us start with anatomy and physiology first. So, this is, you can see it is the hypothalamus, and it is hypothalamo pituitary portal system, and pituitary gland, and this is thyroid gland. Now comes the physiology. We all know that thyroid secretes two hormones mainly, T4, that is thyroxine, and triiodothyronine. So how it is controlled? First of all, we should know something about HP, hypothalamus pituitary thyroid axis. So as you see, hypothalamus, it secretes TRH, that is thyrotropin releasing hormone. So TRH is a protein. It is a protein enzyme, and it is a trophic hormone, which is trophic hormones means those hormones which don't affect directly to the secretory cells, but they act through other endocrinal gland. So TRH, the function of TRH, it is produced in the hypothalamus, and then it is secreted to pituitary gland, where its function is to stimulate thyrotropin cells of the anterior pituitary for the release of thyroid stimulating hormones. As we all know, it also directly, as a non-trophic hormone, it affects the secretion of prolactin from pituitary gland directly. So then it acts on pituitary gland. It causes release of TSH, that is thyroid stimulating hormone from anterior pituitary, which is then which then goes to thyroid, bound with the receptor, and then it stimulates the secretion and synthesis and secretion of thyroid hormones, which we will be discussing in little detail later. So these thyroid hormones, this T4 and T3, they circulate in the blood in attached to this combined to PBG, that is thyroxine binding globulin. And this, they are the secretion of thyroid hormones are controlled by negative feedback mechanism. That is when the blood levels of thyroid hormone, especially T4, is increased, it causes negative feedback, means it causes decrease in the secretion of TSH as well as TRH by negative feedback mechanism. And even this TSH secretion is very sensitive to the circulating levels of T4. So even a small change in T4 levels can cause a very big change in the secretion of TSH. This TSH response to TRH is influenced mainly by T4 levels, but it is also associated with dopamine agonists and glucocorticoids, which cause inhibitory effect on the hypothalamus, and dopamine antagonists, which have stimulatory effect on TRH secretions. Estrogen increases the TRH receptors content of the pituitary. Hence, TSH response to TRH is greater in women as compared to men. And this is more so with women who are taking oral contraceptive pills containing estrogen and progesterone. So this is a negative feedback mechanism, how it is the secretions of thyroid hormones are controlled. Now we come to how the thyroid hormones are synthesized. There are 5 steps of thyroid hormone synthesis. First is synthesis of thyroglobulin. Thyrocytes, mean the thyroid cells, they in the thyroid follicles, they produce a protein called thyroglobulin, or we also call it TG. Thyroglobulin does not contain any iodine, and it is a precursor protein which is stored in the lumen of the follicles of thyroid gland. Then second is iodide uptake. As we all know, the iodine is an essential trace element absorbed in the small intestine. Sources of iodine include iodized salt, seafood, seaweed, and vegetables. Decreased iodine intake can cause iodine deficiency and decreased thyroid hormone synthesis. That's why WHO recommended daily allowance of iodine for a pregnant woman is about 250 microgram per day, which we should keep in mind while we prescribe diet for a pregnant woman. There is a protein kinase A phosphorylation, which stimulates iodine from the circulation into uh, into thyrocytes under the influence of TSH. So, um, under the influence of TSH, that is called iodide trapping. In a normal thyroid gland, the iodide pump concentrate about 30 times of the blood iodide. Then comes iodination of thyroglobulin. Thyroid peroxidase, TPO, which is very important form of enzyme in the thyroid gland, and which is clinically also very important for us in the diagnosis of thyroid disorders. It has three important functions like oxidation, means TPO uses hydrogen peroxide to oxidize iodide to iodine. Just a minute. So, uses hydrogen peroxide to oxidize iodide into iodine. Then comes organification. In organification, the TPU catalyzes linking tyrosine residues of thyroglobulin protein with iodine. It generates monoiodotyrosine, that is MIT, and diiodotyrosine. MIT has a single tyrosine residue with iodine, and DIT has two tyrosine residues with iodine. Then comes coupling reaction. In this also, TPA helps in combining iodinated tyrosine residues to make triiodothyronate and tetraiodothyronate, that is T4. One MIT and one DIT join to form T3, and two DIT molecules join to form T4. So then, after being formed, it is stored in thyroid gland and in abundant amount, and after binding with thyroglobulin. So a normal thyroid gland can store a supply of T4 and T3 for as long as 2 to 3 months. So before any clinical symptoms appear, even the woman is is hypothyroid, but generally the clinical symptoms appear after 2 to 3 months because of this fact. And this stored thyroid hormones, they are secreted in and released into circulation, which is mainly controlled by TSH. So TSH induces a proteolytic process that results in the release of thyroid hormones into the circulation in the form of P4, which is the main part, which is 93, which forms 93%, while T3 is 7%. Daily about 35 microgram of T4 is secreted in the blood. We all know that 70% of T4 and T3 are bound to serum thyroxine binding globulin, that is TBG, and 30% of thyroxine, 34% to thyroxine binding pre-albumin and albumin. And it is also present in unbound form, though very small, which we call free T4 and free T3, which make up only 0.02% and 0.3%. So a few things about T3 and T4. T4 has greater affinity for TBG as compared to the thyroxine binding globulin as compared to T3. So we can see that the mobility of T3 is more than intracellular mobility than T4. And it is mainly the T3, which is the active part, which has the effect of thyroid hormones on all the organs. So it is T3 which is responsible for most of its effect. 80% of the generated T3 is derived from T4 outside thyroid, that is in liver or kidneys. T3 is very potent, 3 to 5 times more potent than T4. And but the half-life of T3 is very low, less means 1 day as compared to 6 days of T4. So this is some few things about T3 and T4. Now, how the thyroid hormones are disposed of and cleared off. So there is an enzyme called deiodinase, which is responsible for the clearance of thyroid hormone, which deiodinate T4 and T3, and like 40% of the secreted T4 is converted to T3, and one third to reverse T3. There are type 1, type 2, and type 3 excretion, means the fate of thyroid hormone, especially T4. We can see that it is pituitary, brain, and even placenta in the pregnant woman. Placenta has the enzyme deiodinase, so it is also responsible for converting T4 to reverse T3 and T3 to T2. So, effects of thyroid hormones on other systems. We all know that thyroid hormone is very important, play very crucial role and important role in homeostasis and the metabolism of different organs, and almost affects each and every organ and system of the body. Like in general, the thyroid hormones, they have a positive or stimulatory effect on every organ. But if it is there are high doses of thyroid hormones, it may be a little depressing. So, like in metabolism, there is increase in BMR, which leads to increased oxygen consumption, respiratory rate, and body temperature. Depending on the metabolic status, the effect of on lipid metabolism, it can induce lipolysis or lipid synthesis. It stimulates metabolism of carbohydrates, but thyroid hormones, they don't change the blood glucose level, but they can cause increased glucose reabsorption, gluconeogenesis, glycogen synthesis, and glucose oxidation. On protein metabolism, they have anabolic effect, but in high doses, they can act as for catabolic. In children, thyroid hormones act synergistically with the growth hormones to stimulate bone growth. It induces chondrocytes, osteoblasts, and osteoclasts. It also helps in brain maturation by axonal growth and the formation of myelin sheath. And on heart, they have a permissive effect on catecholamines, thus increase the heart rate, stroke volume, cardiac output, and contractility. Lungs on respiratory centers, they stimulate respiratory centers and thus lead to increased oxygenation. Skeletal muscles, there is increased development of type 2 muscle fibers, which are capable of fast and powerful contractions. Nervous system, we all know that they have a great impact on nervous system, especially in childhood and fetus. In adults, it can affect mood. Hypothyroidism can lead to hyperexcitability and irritability. Hypothyroidism can cause impaired memory, slowed speech, and sleepiness. Thyroid hormones also affect fertility, ovulation, and menstruation. GIT, on GI, gastrointestinal tract, there is increased gastrointestinal motility, enzyme production, and thus it promotes digestion. So we see that every organ in the body is affected by thyroid hormone. So thyroid and pregnancy. The production and circulation and disposal of thyroid hormones are all altered during pregnancy. So in this picture, you can see that managing thyroid levels during pregnancy is really very crucial and very important as well. So what happens in pregnancy with thyroid? So pregnancy is a natural stress test for thyroid. So we see that how there are changes which take place because in early pregnancy or first trimester, there is increased estrogens in pregnancy, which causes a 2 to 3-fold increase in thyroxine binding globulin, which in turn cause increase in T3 and T4. So the total T4 is normally 1.5 times more than non-pregnant level. Similar and SCG was also increased in early pregnancy, and similar structure of SCG, especially SCG's alpha unit and TSH. So they compete with each other, and SCG stimulates release of T3 T4, which causes decreased transient decrease in the TSH level between 8 to 14 weeks, because during this time the SCG is at its highest level. Then little later in pregnancy, there is increase in the peripheral metabolism of thyroid hormones, and also there is increase in the plasma volume, which means there is the concentration of thyroid hormones decrease. As there is non-functioning of fetal thyroid until 10 to 12 weeks, so the mother has to supply thyroid hormones to the baby. So the thyroid hormones are being siphoned to baby during till 12 weeks. And there is placental degradation of T4, as we discussed earlier also. So all these lead to decrease in T3 and T4, and eventually it leads to increased demand of T3 and T4. That is 30 to 50% increase in the demand, and eventually this leads to increased demand of iodine also. So again, we see that the intake of iodine is very important for a pregnant baby. Now comes a little bit in detail. As we see, the increased serum TBG due to estrogen induced silation of the protein, which leads to decreased renal clearance and longer half-life. Because normally the half-life of TBG is 15 minutes, but now in pregnancy it becomes 3 days. And there is increased total T3 and total T4. So that's why sometimes we have to rely on free hormone assays for diagnosing hypothyroidism or hyperthyroidism in pregnancy. There is increased demand for iodine because there is increased GFR, leading to increased iodine clearance by the kidney and siphoning of maternal iodide by the fetus. So that's why again I'm stressing that WHO, the RDA, means recommended daily allowance, is 200 to 250 microgram per day during pregnancy. TSH is suppressed and free T3, T4 are increased significantly when SCG is highest, as we discussed in last diagram. And it is highest at, SCG is highest at 8 to 12 weeks of gestation. And TSH is suppressed as much as 18% in first trimester, 5% in second trimester, and then third trimester also 12%. So now, again, I'm stressing that the thyroid hormones and fetal has great impact on fetal brain development. So that's why we have to be very careful for maintaining normal thyroid hormone levels. It is very important for nervous system development and brain differentiation, synaptogenesis, and growth of dendrites and axons, myelination, and neuronal migration. So it is really important. So what is hypothyroidism in pregnancy? The hypothyroidism in pregnancy may be overt or subclinical. Overt hypothyroidism is increased in serum TSH more than 10 milli-international unit per liter with a low thyroxine, while subclinical hypothyroidism is serum TSH level in the range of 4 to 10 milli-international unit per liter with normal thyroxine. While several studies have reported 1.5 to 4% prevalence of hypothyroidism in pregnant women. Among them, 0.3 to 0.5% had overt hypothyroidism and the rest had subclinical hypothyroidism. So we see that the subclinical hypothyroidism is more common than overt hypothyroidism. In India, reports on the prevalence of maternal hypothyroidism range between 1.2 to 6.7% in various studies, depending upon iodine deficiency in the particular state. So, what are the causes of hypothyroidism in pregnancy? Iodine deficiency is the most common cause or leading cause of hypothyroidism in pregnancy, especially in the states of India where iodine is really deficient. And iodinized salt is not used in the household. So, if in iodine sufficient areas, the other common cause, second most common cause is autoimmune thyroiditis, that is Hashimoto's thyroiditis. Apart from these, the other causes are radioiodine therapy, thyroidectomy, congenital hypothyroidism, drug use like rifampicin and phenytoin, and any hypothalamic pituitary disease. Women with lower thyroid preconceptual reserve are unable to cope with increased metabolic demands during pregnancy and can enter into the hypothyroid state. So, what are the effects of hypothyroidism in pregnancy? We all know that thyroid hormones play a very crucial role in the maternal and fetal outcome of the pregnancy. So, what are maternal effects in thyroid disorder, especially hypothyroid? The early abortion rate is more as compared to normal population. There is gestational hypertension, that is PIH, preeclampsia. The incidence is 22% in overt hypothyroidism, 15% in subclinical, 7.6% in general population. Placental abruption is also more common in hypothyroidism, 18% in overt, while subclinical hypothyroidism does not cause placental abruption. Anemia. So maternal anemia is 31% in overt hypothyroidism, while there is no association with some subclinical hypothyroidism. Preterm deliveries that especially less than 34 weeks are common with hypothyroidism, and myopathies are also are common. Postpartum hemorrhage is also more common in hypothyroid pregnant women as compared to normal women. Then effects on fetus and neonates. In fetus, there are early abortions, placental anomalies and abruptions, as we saw earlier also. IUGR is more common in hypothyroid women. Prematurity, stillbirths, neurological and developmental anomalies, and cognitive impairment is more common in hypothyroid pregnant babies of hypothyroid pregnant patients as compared to normal. And neonatal effect, there is increased incidence of hyperbilirubinemia and respiratory distress in neonates as compared to normal mothers. So how can we diagnose hypothyroidism? Generally, the symptoms and signs are non-specific. So a patient may complain of fatigue, weight gain, constipation, edema, and all these signs we also see in normal pregnancy also. So it is only the blood investigation, which and evaluation of TSH, which by which we can diagnose hypothyroidism. That's why the importance of doing thyroid evaluation early in pregnancy is evident. So how can we diagnose by blood this? So if we see as this flow chart, we see that If we do the TSH is high, and then we do 3T4, which is if it is low, then it is hypothyroid, overt hypothyroidism. And if 3T4 is normal, then it is subclinical hypothyroidism. If TSH is normal, it is normal thyroid. And if it is low, TSH is low, then if free T4 is normal and free T3 is also normal, then it is subclinical hyperthyroidism. But if T4 is normal and free T4 is normal, but free T3 is also high, then it comes as hyperthyroidism. As it is also with free T4, if it is free T4 is high, we label it overt hypothyroidism. And these are the normal ranges of different hormones in the blood. There are also some antibodies important, like TPO antibodies, as we discussed earlier, thyroxine peroxidase inhibitor antibodies, or TSH receptor antibodies, or anti-TG antibodies, which play an important role in thyroid disorders as as immunological etiology. So, in case of diagnosis, sometimes we need the help of these markers, and then means we can differentially diagnose. So, how should we manage hypothyroidism in pregnancy? The goal of treatment, as advised by an Indian Thyroid Society recommendation, it is TSH levels should be kept in first trimester 2.5 milli international unit per liter or less. In second and third trimester, it should be 3 milli international unit or less or per liter or less. So this is how should be our target. By giving this remark, I will tell later. So what is the treatment? So we give thyroxine replacement therapy. So levothyroxine is used to treat hypothyroidism. In subclinical hypothyroidism, it may not require any treatment, or if TSH is minimally elevated, that is less than 10 milli international unit per liter in pregnancy, then we can try with 0.075 to 1 milligram of levothyroxine per day, which is often adequate. If it is over hypothyroidism, TSH is high but less than 10, then we add 50 microgram per day. Uh, TSH is if more than 10 and less than 20, we add 75 microgram per day. If TSH is more than 20, we add 100 microgram per day. Well, friends, but generally what we do is prefer to do is whenever there is hypothyroidism, we always take opinion of our learned endocrinological colleague. As I many times or almost every patient I refer to Dr. Rana Bhattacharjee. So we should take their opinion also, and accordingly we can customize our treatment. So, in a diagnosed case of hypothyroidism, readjustment of the dose in pregnancy depends on the etiology. That is, in Hashimoto's thyroiditis, 25% increment of dose is required, while in atherosclerosis, like Graves' disease after iodine 131 therapy, 45% increment is needed. TSH should be monitored every 8 to 10 weeks, or if a dose adjustment is made, should be checked 4 weeks later. 25% of those with initial normal TSH levels in the first trimester, and 37% of those with initial normal serum TSH in second trimester will later require doses increases. And before that, there is two important points I would like to highlight is that whenever we prescribe thyroxine, levothyroxine, we should tell the patient to take it 4 hours, means 4 hours before and 4 hours after after taking levothyroxine, she should not take calcium or iron because otherwise absorption is hampered. And secondly, she should be using same brand of levothyroxine. She should not be changing without doctor's advice. So this is all about how can be managed. And my take-home message is thyroid hormones play a very vital role in the maternal and fetal outcome of pregnancy. Thyroid hormones alter and fluctuate throughout pregnancy. And every pregnant woman's thyroid hormone should be evaluated on her very first visit to antenatal OPD and should be re-evaluated after second trimester. Thank you very much for your patient hearing. Thanks. So I hand over to Dr. Rana Bhattacharjee. Dr. Bhattacharjee.
Yeah, thank you, Dr. Jain. Can you please stop sharing from your end, so that I can share mine?
Yes. Madam, you can unshare your screen so that sir can share.
Yeah.
Thank you.
Thank you very much, sir.
Yeah, I hope my screen well visible now.
Yeah, sir. It's
very good evening to all of you, and thank you, Dr. Jain, for your beautiful introduction to the main topic, as well as for the invitation, and thank you, Shuman, as well. So today we'll discuss hyperthyroidism in pregnancy. Dr. Jain has already discussed the physiology and hypothyroidism. So what I will do, I will just carry forward the discussion in a case-based manner, so that, I mean, the patients that you see in day in and day out, you can relate to that during the discussion. And of course, you can take the questions at the end of the session. So we'll start with this 20-year-old lady who is married recently, LMP 2.5 months back. Now referred for altered TFT. And this is the thyroid function test. As you can see, there is slight elevation of T3 and T4. And TSH is 0.21, which is less than the range that is given by the lab. So what has actually happened? Now here, Dr. Jain has discussed all those points. Just to highlight few of those, that initially in the first trimester, the HCG level increases, which stimulates thyroid hormone production. So that leads to both increase in total as well as free T3 and free T4. The thyroid binding globulin starts increasing from the late part of the first trimester onwards. So there is disproportionate elevation of total T4 and total T3. And other changes have already been discussed. I won't go into detail of those. But another very important point from the clinical aspect is that pregnancy itself is a hypermetabolic state. So few signs and symptoms like palpitation, tachycardia, mild tiredness, all those things which can happen in normal pregnancy actually mimics the presence of thyroid disease. This is one of the very important picture which actually depicts the different important chemicals that crosses the placenta to the fetus. As you can see, the TSH does not cross placenta, but thyroid receptor antibody does. So if the TRAB level is high in mother, it can freely cross the placenta, leading to the fetal thyrotoxicosis. But high TSH level does not cross placenta. T4 and levothyroxine crosses placenta, although not very freely, but they can cross to a significant proportion. The iodine also crosses the placenta. Among the drugs, the antithyroid drug like PTU and methimazole also crosses the placenta, and we can utilize this property to treat the fetal thyrotoxicosis. But you must remember that they can also induce fetal hypothyroidism if not used in a proper context. Radioactive iodine if administered during pregnancy, it, as you can see, it freely crosses the placenta just like iodine and causes fetal thyroid gland destruction. So this is in brief the changes of various thyroid hormones and TBG and HCG during various trimesters of pregnancy. And it's important to know that in the later part of the pregnancy, the fetal thyroid hormone production starts. And so 20 weeks onwards, there is a chance of fetal thyrotoxicosis if the maternal level of thyroid receptor antibody, which stimulates the thyroid gland, is high. So when we talk about the normal range, Dr. Jain has already discussed. The recent American Thyroid Association recommends that it's best to have a population-based trimester-specific reference range. Okay, so the older range that we had, actually, they have suggested to modify it according to your local criteria. And what we have done, we actually did this study in our institute, and we have actually established the cutoff for the areas that is in and around Kolkata and West Bengal. So this is possibly can be extrapolated to the eastern part of India as well. So here you can see the normal TSH levels were given here. In the second and third trimester, it is slightly lower than the TSH in a non-pregnant state, but in first trimester, TSH level is normal, TSH is quite low. So if you want this reference, you can note down this citation. This was published in Indian Journal of Endocrinology and Metabolism. So coming back to this patient, as you can see, there is slight elevation of total hormones, but free hormone levels are possibly normal, because as Dr. Jain has said, that you can multiply the upper limit of normal by 1.5 to get the actual normal range, which is adjusted for pregnancy. And as you can see, the T4 and T3 are well within the normal range, and TSH of 0.21 actually fits within the normal range for the first trimester of pregnancy. So essentially, this patient has normal thyroid function test in pregnancy. She does not have any thyrotoxicosis. Okay, so there is no need to further evaluation or treatment for this patient. But if the patient truly develops thyrotoxicosis, what are the causes? The reasons, the causes which I marked in blue are actually pregnancy-specific conditions. Okay, the other conditions which can occur in a non-pregnant individual can also affect a woman who is pregnant. The commonest cause of thyrotoxicosis in pregnancy, if that is truly present, is transient gestational hyperthyroidism. This is due to excessive secretion of beta HCG. So coming to this patient, regarding the other pregnancy-specific causes may include multiple gestation, hydatidiform mole, and some TSH receptor mutation, which actually makes the TSH receptor overtly sensitive to HCG. So an increase in HCG can lead to stimulation of TSH receptor, causing thyrotoxicosis. And Graves' disease is also not very uncommon during pregnancy, but other causes are relatively rare. So this 28-year-old lady who is in second pregnancy, LMP 8 weeks back, presented with vomiting, palpitation, anxiety, and she had similar episode in her last pregnancy. She is a bit tachycardic, but there is no thyroid buoy, and as you can see, there is no goiter, and there is no thyroid associated orbitopathy as well. The T3 and T4 is very high, and TSH is suppressed. So what does this patient have in the second trimester, first trimester of pregnancy? Actually, as I was saying, this kind of picture is commonly seen in gestational hyperthyroidism, which is in fact the commonest cause of thyrotoxicosis during pregnancy. It occurs in about 1.5% of pregnancy. Usual presentation is nausea, vomiting, weight loss, ketonuria, dehydration, dyselectrolytemia. And very often it's associated with hyperemesis gravidarum. Okay, and there is symptoms in antedating conception is absent, but in previous pregnancies similar symptom can happen as in our patient. And you can see it's sometimes may be difficult to differentiate it from the Graves' disease, but I have highlighted these three important points: that no symptom prior to conception, no goiter or very minimal goiter, no bruit over thyroid, no thyroid associated orbitopathy, and lesser elevation of T3, and negative antibody, particularly thyroid receptor antibody. These things differentiates the gestational thyrotoxicosis from the Graves' disease, which is another common cause of thyrotoxicosis during pregnancy. It's important to differentiate these factors because here in gestational thyrotoxicosis, you do not need antithyroid drug, you do not need beta blocker, just give supportive management, antiemetics, and the conditions will wane off spontaneously beyond 20 weeks of gestation. So the policy is wait and watch. Coming back to a third patient, a 26-year-old lady, also in second pregnancy, LMP on 22nd June. The patient presented to us on 11th December back in 2011. She has diagnosed Graves' disease 2 years back and underwent iodine ablation twice, once in 2010 and the second time in 2011, with 8 and 10 millicurie doses respectively, but still the thyrotoxicosis was there. The carbimazole dose was 60, gradually reduced to 15 milligram once the patient became pregnant. Now this is one of the very important points you need to remember, that during pregnancy, sometimes thyrotoxicosis, if it is due to Graves, tends to get better with time because of immunosuppressed. As you know, the pregnancy is an immunosuppressed state. The patient stopped the drug herself 2 weeks back and presented with orthopnea, palpitation, edema, and nausea and vomiting for the last 3 days. Okay, so what's the striking feature here? As you can see, the LNP was 22nd of June, and patient received the radioiodine therapy just before this pregnancy. So the gap is practically very small, just 1.5 months, which is totally undesirable. Now, we'll discuss some very important points regarding iodine 131 therapy and pregnancy. It's absolutely contraindicated during pregnancy, as I was saying, that it freely crosses the fetal, the placenta, and can affect the fetus. After 12 weeks, it can lead to fetal hypothyroidism. And in the early pregnancy, there is a chance of mutagenesis because during the stage of organogenesis, the fetus is exposed to radiation that is potentially harmful. So it's always important to ask for a pregnancy test 48 hours before the ablation, and we usually ask for serum beta HCG, not urine beta HCG, because that can pick up the pregnancy even earlier. Pre-pregnancy, we should delay conception for at least 6 months. This is mainly due to stabilization of thyroid function, but also there are some reports that if the patient conceives earlier, there can be increased chance of miscarriage, aplastic anemia, and Edwards syndrome in the child. But if we wait for at least 6 months, it's reasonably safe. But sometimes the thyroid receptor antibody level may be high, may remain high for at least 1 year, but this is not a contraindication for pregnancy. So basically, we should wait for at least 6 months for conception after a radioiodine therapy. So coming back to our patient, the patient has various features of a condition. We call it thyroid storm. It itself is a problematic condition. It's a life-threatening condition. Moreover, during pregnancy, it's even difficult. The thyroid, both the thyroid hormone levels are still high, the T3 and T4, and as you have seen earlier, the TSH is very much suppressed. The patient has some degree of hepatic dysfunction, and urine protein is positive. USG fetal profile, however, is not that bad. The cardiac activity was good. fetal heart rate was 186, but the fetal thyroid morphology was normal. The liquor is bit scanty and placenta is anteriorly placed. So what are the important USG signs of fetal hyperthyroidism? It's very important. Once we document the high level of thyroid receptor antibody, we should monitor for the fetal hyperthyroidism. The goiter with central vascularity pattern is very important. This is the goiter. This is the normal thyroid gland. This is not from our patient. This is taken from another patient. The fetal heart rate more than 170 beats per minute, which persists for more than 10 minutes, is suggestive of the fetal thyrotoxicosis. And there can be accelerated bone maturation. Plus, there can be features of iugia. There can be congestive heart failure, which can be picked up by fetal echocardiography. And rarely, very rarely, there can be hydrops fetalis. So this patient, the fetus has a heart rate of 186 beats per minute. So there is a suggestion that some degree of fetal thyrotoxicosis is there. So what's the problem with our patient? There are various maternal issues like uncontrolled Graves' disease with a potentially life-threatening condition of thyroid storm. Patient is having a high output heart failure as evidenced by pedal edema as well as echocardiography, and patient is also having bronchial asthma. It's very important to avoid the obstetric complication in this patient, possibly the proteinuria, which may suggest the presence of preeclampsia. There are other fetal or neonatal issues like hyperthyroidism in fetus and neonate. The fetal hyperthyroidism is possibly there in this fetus. And other kinds of hypothyroidism can also develop in fetus and neonate because of various other factors. If you're interested, we can discuss those into the Q&A session. So what are the treatment for the therapy in the Graves' disease? So as you can see, that when it's diagnosed during pregnancy, the radioiodine therapy is out of question. The medical therapy is the mainstay of therapy. The problem is that the two drugs that are available to us, that is methimazole and carbimazole, are actually akin to choosing between the devil and the deep blue sea. So as you can see in this picture, the methimazole can lead to some fetal problems. The majority of the newborn can have aplasia cutis, but other cardiac malformation can also be there. PTU can also lead to some congenital malformation, but that is rare. But the patients who are without medicine can also have the congenital malformation. And uncontrolled thyrotoxicosis in pregnancy can lead not only to congenital malformation, but also leads to various adverse obstetric outcomes, like the abortion or later on the stillbirth, and increased incidence of preeclampsia and eclampsia and so on and so forth. So keeping the patient untreated is also not an option. So it's really a difficult choice between us. But fortunately, the aplasia cutis, which is typical with methimazole, it's not very severe. It's just usually manifests as a mild patch of loss of or absence of skin patch on the scalp, which may need a small plastic surgery procedure. If we look at the various drug safety in pregnancy as mandated by FDA, the PTU, carbimazole, and potassium iodide all are category D drug. That is, they can cause fetal harm, which is documented. But despite that, we may need to use this drug. And dexamethasone and hydrocortisone can cause potential harm to the fetus, but they can often be used for lung maturity. So despite this, we have to use this drug in this condition. So there are some set of recommendations that we have to see that patient really needs antithyroid drugs. If the antithyroid drug is needed, usually for the first 16 weeks, we prefer PTU, but there are some thought process that methimazole can be used because PTU, on the other hand, can be associated with severe hepatic dysfunction, the fulminant hepatic failure in mother. And worldwide, after paracetamol, this is the second most cause of fulminant hepatic failure. So this is also a difficult choice, but if PTU is used in the first 16 weeks, we usually switch to methimazole after 16 weeks. We monitor thyroid function test every 2 to 4 weeks, usually 4 weeks till the patient is stable. And as I was saying, in the second half of pregnancy, many a time the requirement for antithyroid drug is reduced. And after 34 weeks, around 1/3 of the patient can we can take off the drug, and the patient can maintain the euthyroid state without any antithyroid drugs till the delivery. But please remember, after delivery, there is a chance of flare of Graves' disease. So please recheck the thyroid function 4 to 6 weeks after delivery, because some patients can have very severe recurrences. Adverse drug reaction is usually rare for mother. Agraenocytosis is very rare, which is a severe side effect of antithyroid drugs, but that can occur in non-pregnant state as well. Hepatotoxicity, although rare, but as we were saying, it's more reported with methimazole. PTU, not methimazole. So it's preferable once you start therapy to have a baseline blood count and liver function tests, because subsequently to look for agraenocytosis hepatotoxicity, you need this baseline values. So what we did in our patient was started with oxygen inhalation as there is heart failure with salt and fluid retention. We started PTU because the PTU is also, as I was saying, that it's usually used before 16 weeks of pregnancy. But as this patient has thyroid storm, the propylthyrosol actually, in addition to the inhibition of release of thyroid hormone from the thyroid gland, it also inhibits the conversion of T4 to T3. And if you remember, Dr. Jain has told you the T4 is possibly a kind of prodrug and T3 is the more active drug. So the PTU, unlike methimazole, it, in addition to the release from thyroid gland, it blocks the conversion of T4 to T3. Verapamil was given as the beta blocker, cannot be given as the patient is also having asthma. Alpha methyl dopa was started for hypertension. She was put on inhalation therapy for asthma. The supplementation was given, and due to the presence of anemia, the RBC transfusion was done. And we monitored the patient subsequently with the trimester specific reference range. Please remember, the target here is not TSH. The target is either free T4 or adjusted T4, which should be kept at the upper half of the normal or slightly more than the upper limit of normal. So this is the target. We should not keep it in the low normal range, let alone the lower than the normal range for pregnancy, because that can increase the chance of fetal hypothyroidism. As I was saying, that both methimazole and PTU crosses the placenta and can cause fetal hypothyroidism if used in a very large dose. So if there is normalization of TSH during therapy, you must reduce the dose, because that indicates over-treatment. In our patient, with treatment, the gradually heart rate and blood pressure stabilized. The T4 level also tend to, the trend was toward downwards at 2 weeks, and after 4 weeks, the FT4 became normal. We again reduced the antithyroid drug doses, because as I was saying, this is in the lower half of the normal range, which is not desirable. But the good thing is that the fetal heart rate also stabilized, possibly due to the effect of the antithyroid drugs, which crossed the placenta, and it acted as a treatment for the fetus. Now, what is the role of thyroid receptor antibody during pregnancy? As I was telling multiple times, that fetal TSH receptor antibody, fetal thyroid starts responding to the TSH receptor antibody 20 weeks onwards. So therefore, it's indicated to measure that, and if it's elevated, we should do fetal surveillance, particularly if it is 3 times than the upper normal limit. So this is the recommendation for ATA. that they ask for 3.3 time period, but we usually do it at between 18 to 22 weeks because of cost constraint for many of our patients. So in a mother who is a known case of Graves' disease, we usually do thyroid receptor antibody between 18 to 22 weeks. Surgery is very rarely needed because there are chances of associated morbidity and mortality, and moreover, the drugs are reasonably safe and at least safer than the surgery during pregnancy. But if it's absolutely needed, the second trimester is the ideal time period. Sometimes, very rarely, we encounter a problem like maternal hypothyroidism with fetal hyperthyroidism, particularly when the TRAb level is high, but mother is hypothyroid, like preceding radioiodine therapy. So in these conditions, sometimes we have to give a combination regimen, like we give levothyroxine to treat the mother. Along with that, we give the methimazole to treat the fetus. But this is a rare situation. So back to our patient. She was discharged on PTU, methyl dopa, and asked to follow up with FET4, doing well, but noticed reduced fetal movement at 36 weeks, and the obstetricians advised the delivery, and baby was delivered at 36 or 37 weeks. The patient and the newborn was monitored closely for development of hypo and hyperthyroidism, both clinically as well as by thyroid function test, because both can develop in a newborn with a mother with Graves' disease. So this is one of the important factors that we have to remember. Lactation is not a contraindication for antithyroid drug. So you can use antithyroid drug during lactation, but sometimes we tell to administer the drug just after feeding the child to minimize the exposure of the newborn to the antithyroid drug. So at the end of this discussion, the takeoff messages are we should have a trimester specific TSH, and subnormal TSH, if we find that, we should check T4. In pregnancy, the Graves' disease, the gestational thyrotoxicity is the commonest cause, followed by the Graves' disease. We should advise pregnancy test 48 hours before radioiodine ablation. Particularly, the most useful test is serum beta HCG, which we usually prefer. And we try to minimize early fetal exposure of to antithyroid drug. So initially, when the patient becomes pregnant or trying for pregnancy, if the thyrotoxicity is very mild, I mean, sometimes we do not start treatment, or even if we start treatment, once the patient becomes pregnant, we sometimes take off the drug. But it's moderate to severe, of course, you have to continue, because not treating a patient with moderate to severe hyperthyroidism is not an option. We should reevaluate the need for antithyroid drug prior to therapy and during pregnancy, prior to pregnancy and during pregnancy. And if antithyroid drug is needed, I have discussed the choices, and the same should be discussed with your patient. And strict monitoring is a must, and we should keep the FET4 level around the upper normal range. And if indicated, the proper fetal and neonatal surveillance should be done. Thank you all for your patient hearing. I'll hand over to Dr. Jain for further proceedings. If you have any question, I'll stop sharing my screen here. Thank you again.
Thank you very much, sir, and thank you very much, madam, for this nice presentation. And sir, just give me 1 minute to collect the question from the dashboard.
Sure.
So, first question is for ma'am, that from your practical observation, which thyroid disorder, means I can say this is hypo or hyperthyroid disorder, is the most prominent in Indian pregnant women, if you say particularly in terms of eastern part of India, and which one is the more detrimental in case of this pregnancy? Madam, you are in mute.
In my practice, I have seen more of hypothyroidism as compared to hyperthyroidism. And what do you say, Dr. Bhattacharjee?
Yeah, I do agree. It's much more common than hyperthyroidism. Hyperthyroidism is much more common.
Is there any specific reason for that?
It is more, as I told you, mostly it is due to iron deficiency because there is no awareness of taking iodized salts and iodine in the diet. So it is more due to iodine deficiency, but this thyroiditis is also second common cause. Hashimoto's thyroiditis.
Okay, thank you. And sir, I have one query that in case of thyrotoxicosis, so what will be the appropriate approach to treat a particular?
Approach means how to diagnose
Yes,
or how
yes,
to
yes,
treat.
sir. Yes, sir. How to diagnose and treat?
As I've said, it depends on the trimester. Now we have a trimester specific reference range from eastern part of India. So that's already published. I've shown you the data. So if the TSH is below the normal range and T4 is elevated, particularly the either FT4 or pregnancy adjusted value of total T4, it is more than the upper limit of normal, then we diagnose the patient as having hyperthyroidism, and if it's moderate to severe, we need to start treatment immediately. But again, please keep in mind that there are many causes of hyperthyroidism in pregnancy, and the commonest cause is gestational thyrotoxicosis, but the thyrotoxicosis is a mild one, and there we should not give any antithyroid drugs. The treatment depends on the cause of thyrotoxicosis.
Thank you, sir. And sir, another question is, I mean, in recent research study, some research study shows that there is a close relation between the high thyroid, means thyroid dysfunction and the gestational diabetes mellitus. So, what is your opinion on that?
Actually, see, this is kind of an association study. As such, the thyrotoxicosis leads to the gestational, not only gestational, as such, it leads to the glucose intolerance because of many factors. Most important is rapid GI absorption and also some insulin resistance. That factor is exacerbated in pregnancy, but truly speaking, the development of thyrotoxic, gestational diabetes mellitus in uncontrolled thyrotoxicosis is least of our problem possibly, because much more challenge is how to control the thyrotoxic state with the drugs. And if gestational diabetes is due to thyrotoxicosis, it often abates with the therapy. But if it still persists, we should treat gestational GDM as per our guideline and our experience.
Yes, and in that case, ma'am, I just want to know one thing that in that case, if you say thyroid dysfunction and GDM, so when you just manage this thyroid dysfunction, does this GDM goes away or it is persisting for the particular pregnant woman?
Sorry?
If the thyroid dysfunction means, sir has already told that agreed that there is some relation between these two as well. So in that case, if you manage this thyroid dysfunction, so does this GDM goes away or it will persist throughout the gestational period?
No, I think it will persist. Because the blood glucose levels are generally not controlled by thyroid hormones. So once and it is pregnancy induced, more of pregnancy induced. So I think it will persist.
Okay, ma'am.
Okay, I think we are.
Yes. So yeah. Yes, and I could not find any other question. So if you allow me, then we can close this session for today.
Yeah, definitely.
So thank you very much, madam, and thank you very much, sir, for your valuable time in our platform. And in future also, I look forward for some valuable session from you both, sir.
Thank you. Thank you.
Thank you. Thank you, madam.
Dr.
Thank you, sir.
Bhattacharjee, good night.
Yeah,
Good
good
night.
night. Good night. Good night.
Thank you.